Alright guys, today we're going to set up the ventilator in SIMV PRVC mode that we use here at Med Evac for most of our transports. So the first thing I've done is picked my adult circuit that's over here. I've put on my bacterial filter and I've put in all three of my pressure lines. And just make sure those are on there really tight. Those will generate some pretty big alarms for you if they're not. All right, so now once this is all done and we have our test lung also in place, we can turn the ventilator on. So press and hold this on the bottom. All right, so you're going to get some alarms that go through here. Go over and press the yellow alarm silence button and clear those alarms before you can go through and select what you're going to do. We're always going to select new patient. We never want to select same patient unless we set this vent up on the way to a scene call and we know that we were the ones who put the last ventilator settings in. So if this is on a new patient, we're always going to select new patient, which I use the toggle switch to get to. Select that. I'm going to toggle past patient ID to patient size. This is going to be an adult, so I'll select that, and he's intubated. So these are the backup settings that the vent is going to give you. I tell everybody to work from their top down every single time we set the vent so that we don't miss anything. Up here is going to be your generated values. So this is what based on the values you pick down here, this is what is happening inside the patient's lungs and what the patient is doing. So the first thing we're going to do is select SIMV PRVC. You can see that it has defaulted into AC volume. So we're going to select that, come down to the toggle switch, go down to SIMV, and then PRVC. The reason we pick PRVC is that it's a special mode. It means pressure regulated volume control. It's similar to just a volume control mode, but every single breath it's going to try and give it at the least amount of pressure possible, whereas SIMV, just regular volume control, is not as intuitive, so it won't change the forceful driving pressure that it takes to deliver the breath every time. And we know that driving pressure and those peak inspiratory pressures are really what causes the trauma in ventilated patients, not excessive PEEP. So this is in and of itself a lung protective strategy. So that's the one we want to try and use on most of our patients. So once we've selected the mode of ventilation, we're going to come up and select your I time. That'll be dependent on what your patient is doing and your end-tidal CO2 and your ABGs. So normal for an adult is 12 to 20, so that's fine. Go through and select your I time. A normal adult I time is 1.0. In a few minutes, we'll talk about some more aggressive strategies where we can start moving that I time, but this is a good starting spot. And then your tidal volume. This is going to be dependent on your patient's ideal body weight. So we use between 6 and 8 cc's per kilo for body weight. So you're going to take your patient's ideal body weight and multiply that by 8 cc's per kilo if they don't have lung disease, and 6 cc's per kilo if they do, and that'll give you your generated tidal volume. So do your calculation, pick your tidal volume. And then we're going to move on. The next one is pressure support. This is different than pressure control. Pressure support is only present on the patient's spontaneous breaths, so the vent is going to give the patient 12 breaths. If their total respiratory rate is 20, that means 8 breaths, they're only going to get pressure support and PEEP. So pressure support is just give a little push when they breathe in to help them generate their own tidal volume and help them overcome the resistance and all the tubing and everything in the circuit. So it just helped to generate their own tidal volume. So when we set this, 10 is a good starting spot. Then you want to go up here to your patient generated values. You want to go up and find your spontaneous exhaled tidal volume. So there's your exhaled tidal volume. That has to do with what your vent is doing for you. Here's your spontaneous exhaled tidal volume. This is what the patient is generating on their pressure supported breaths. So if you compare these two numbers, you want them to be close. If you want your patient to be getting 400 on their ventilator breaths, you're shooting for close to 400 on your pressure supported breaths as well. So titrate up or down on that to get good spontaneous tidal volume. And then your PEEP. 5 is a good starting spot for us, and then depending on their FiO2, their ABGs, and their sat probe, we will then decide how much PEEP we're going to put on there. Your PEEP and your FiO2 are the two things on this ventilator that will allow you to change what their SATs are, and then their respiratory rate and their tidal volume are the two ways to affect their CO2. That's very important when you're reading ABGs to know which values will help you with which settings on your ABG. So we've done this whole top row. We've picked SIMV, PRVC. We'll go down here and start our patients off on 100%, or if we're doing an interfacility transport where they were at before. And then our patient sensitivity. 2 is a great place to be, and this is in liters per minute. So there's always 40 to 60 liters per minute flowing through this circuit. This means the patient has to trigger a change of 2 liters per minute for the ventilator to know that it wants a breath. You can change this up or down. If you do, the smaller the number means the more sensitive. So they only have to exchange 1 liter per minute right now to know, for the ventilator to know they want a breath. So you can change that on some of your pediatric patients or your patients that have very low tidal volumes. That's very helpful. So now we're going to come down to our alarm line. This is your low peak pressure. These are preset, and they are pretty decently preset for our adults. This is a pretty low minute ventilation. When we talk about minute ventilation on adults, we like to see our minute ventilation somewhere between 5 and 8 liters per minute. So it's perfectly acceptable to change this up to 5, but I will tell you that these 2 presets are an okay place to stay. The one that we want to talk about is our high pressure limit. This is something that is going to be really important with our PRVC mode. So we want to make sure that if our patient is generating really high peak pressures, that our ventilator is going to cycle off and protect our lungs. The way we're going to pick this is we're going to come up to the patient generated values. We're going to look at what their peak inspiratory pressure is right now. So right now it's between 24 and 27. So if we leave this at 40, that means that that patient's that the alarm is not going to tell you that their lungs are getting tighter or that something is happening, meaning the ventilator has to push harder to deliver this tidal volume until it reaches 40. So I like to set this a lot tighter than the ventilator does their presets. I like to set it 5 to 10 above where my patient is. So on a patient like this, I would normally set it at 30. Same thing with patients, with pediatric patients. You want to know pretty early that your patient is starting to have compliance changes, and your peak pressure will tell you that pretty early on. So making that a little more sensitive will only make you ahead of the game a little bit more. So we've set all of these and everything is functioning correctly down here on the ventilator. Here's one thing a lot of people like to check when you're in this mode is your plateau pressures. So down here is a maneuvers button, and that is where you're going to be able to check your inspiratory and your expiratory hold maneuvers. The one thing you need to remember is that you need to be in a strict volume control mode before you can check any maneuvers. So we have to come up here to this breath type button. We have to turn it up to volume, and then we can go into our maneuvers button. Your first thing that comes up is your I hold, which is your inspiratory hold. If you toggle past that, it's your expiratory hold. So your expiratory hold is going to tell you what your auto PEEP is, and your inspiratory hold is going to be able to tell you what kind of driving pressure and what kind of plateau pressure and what kind of compliance your lungs has. So really, how sick are your lungs? So once we have it on the I hold, you're going to press that maneuvers button, and you have to time it to where the breath, till before the breath, and just briefly hold it. So our plateau pressure was 22, our static compliance is 19. When we're talking about these numbers, we want our plateau pressure to be definitely below 40, but I will tell you that I like them below 30 if we can. And so between 30 and 40, we need to start looking at what's going on with our patient. Do we need to start changing some ventilator settings or diurese our patient? Does our patient need some bronchodilators, things like that, to decrease that plateau pressure? But that's how you're going to pull that. So when you're done with that maneuver, you'll come back and you'll dial that back down to PRVC where you were before, and you're good to go. One thing we hear people ask is that when you're in a pressure control mode, so your patient's lungs are very sick, how to pull this maneuver. You can't pull it unless you switch into volume, and if your patient's lungs are really sick and you've already determined they can't be in volume ventilation, that you've chosen pressure ventilation, switching into volume just to get this number will not do you a whole lot of favors, because it's going to probably cause your patient to decompensate or not get the delivered tidal volume and pressure that they need just to pull that maneuver. So if they're sick enough to need pressure control, their PIPs are really high, you can assume that their plateau pressures are pretty high as well. So might not be worth the trouble it's going to cause you if you're already in a pressure control mode. So once we've chosen all that, I always tell people, once the front of the ventilator looks like you want it to, go back up here and start toggling through everything so you know where your normal values are before you start your transport. So you know where your peak inspiratory pressures are. Your spontaneous frequency is your spontaneous respiratory rate, so how much over the ventilator is your patient breathing. Your F is your frequency, that is your total, that's what the vent is doing for you. This is your peak flow. This is what is going through your circuit right now in order to deliver the tidal volume that you need. And then here's your VTE, that's your exhaled tidal volume. We talk a lot about this number in order to, especially when we're in pressure mode, so when we're in pressure control and we're in non-invasive modes, this is how we determine a lot of things. So you're putting in 315, this is what the patient's putting out, meaning they're entraining a little bit more tidal volume for you. That's important to know. Here's our spontaneous VTE, our spontaneous tidal volume that we talked about again, that has to do with your pressure support number. How big of a breath is your patient taking on their own? Are they really struggling? Do they need more pressure support, or are they pulling really big tidal volumes? So that's where you're going to find that. Your VE is your minute ventilation. So we talked about that a minute ago. Here's your minute ventilation alarm down here. Ideal minute ventilation for our adults is 5 to 8 liters per minute. Remember, the sicker they are, the higher minute ventilation they're going to need. So you're going to need to be closer to that 8. When we talk about babies, we talk about 8 to 12 liters per minute for a minute ventilation. There's your I/E ratio. If we want to, you'll notice down here there's nowhere where we can pick our I/E ratio. It is generated off of our I time. So if you're doing anything else and you decide, I want to do something different with my I time, as soon as you hit your I time, your calculated I/E will come up. Right now we're at a 1 to 4, which is pretty good for our obstructive patients, our COPD, and our asthmatic patients. If we want to make that longer, we will lower our I time. So there'll be less time in the inspiratory phase, more time in the expiratory phase, which is what we're seeing up here. If we get deeper into lung issues and oxygenation issues, we can start messing with that I time when we talk about inverse ratio ventilation. When we decide to do inverse ratio ventilation on our patients, we have maxed out everything we can do. So you are probably on well over 10 of PEEP, probably 15 to 20 of PEEP at this point. You are on 100% FiO2. And you have messed with your tidal volume and your respiratory rate, meaning that you are in a full ARDSNet protocol setting. So you have a high respiratory rate, you have a pretty low tidal volume, and you are trying to get a good minute ventilation going for that patient. You're maxed out on your PEEP, and you're maxed out on your FiO2. If this isn't working for you, you're still having PO2 and SaO2, your SAP problems, then we can start, like I said, looking at that I/E ratio. So right now, we're at a 1-to-1 I/E ratio with our respiratory rate. That's pretty good, a 1 to 1.7. So that's really close to a 1.2. So if we want to start changing that, we're going to hit our I time, and we're going to start elongating our inspiratory time, meaning less time in exhalation. So right now we're at a 1-to-1. We're at a 1 to 4, 1.4 inspiratory time. So that means you're in equal time inspiratory phase as you are the expiratory phase. Now where we talk about really good oxygenation is when you completely inverse that. So you're in a 2-to-1 I/E ratio. So let's see what that looks like. So I'm looking up here, I'm titrating my inspiratory time till I get to a 2-to-1, and it's going to limit me because it can't do that with the tidal volume and the respiratory rate. We can come over here and mess with this. So look what my IDE calculation is doing over here, just messing with my respiratory rate as well. So once you hit your limit with your inspiratory time, you can still make a change with that with your respiratory rate. All those things affect that. So I'm gonna get as close as I can to that 2-to-1 IE ratio. So that's what I'm in, a 2.2 to 1, meaning 2 seconds inspiratory, 1 second expiratory. So double the time for oxygen to diffuse. And that point where those lungs are popped open for double the time that they're in exhalation is where you're going to get that pure oxygenation and driving that PEEP and that FiO2 into the atelectasis and all those alveoli that are collapsed down there. So that is our strategy when we start talking about normal PRVC, SIMV, and then when that starts to go wrong for you, you can do your ARDSNet protocol, which are those settings we said here. So your faster respiratory rates, your lower tidal volumes, and then if that doesn't work for you, you can start messing with your PEEP and your FiO2, and then if that is not achieving the blood gas or the sats that you need, then you can start messing with your inspiratory time and your respiratory rate to get that good I to E ratio that we're looking, that inverse I to E ratio that you're looking at.